This is a video in clinical medicine from the New England Journal of Medicine.
This video will discuss suprapubic bladder aspiration in children, both with and without the use of ultrasound guidance. Familiarity with this procedure is important when neither a clean catch urine sample nor a urethral catheterization specimen can be obtained. Suprapubic bladder aspiration is performed to obtain a sterile urine sample from children when the urethra cannot be adequately visualized, such as in girls with labial adhesions or labial edema, in uncircumcised boys with unretractable foreskins, in children with conditions such as severe protracted diarrhea that may make it difficult to obtain a sterile specimen, in children in whom multiple unsuccessful attempts have been made to obtain urine through urethral catheterization, and in children with a history of urethral or introital surgery in whom it may be difficult to perform catheterization. Before beginning the procedure, explain to the patient's family or guardian the purpose of the procedure and its risks and benefits, and give them the opportunity to ask questions. Some institutions may require written documentation of informed consent. Contraindications to performing suprapubic bladder aspiration include major genitourinary abnormalities, infections of the abdominal wall, clinically significant bleeding disorders, and massive organomegaly. Gather the necessary equipment. You will need topical anesthetic cream and an adhesive bandage, 1% lidocaine with or without epinephrine, a 25-gauge 5/8" or 1-inch needle, a 22-gauge or 23-gauge 1.5-inch needle, 2 sterile 5-milliliter syringes, sterile gloves, a sterile drape or towel, antiseptic solution with sterile gauze, a sterile specimen container, and a bandage. Apply the topical anesthetic to the skin 1 to 2 centimeters superior to the pubic symphysis and cover with an adhesive bandage. The anesthetic will be most effective if applied approximately 20 to 30 minutes before the procedure begins. If you are performing the procedure on an infant, dip a pacifier or care provider's finger into a sucrose solution and allow the infant to suck during the procedure to decrease discomfort. In older children who have thicker abdominal walls, use a subcutaneous injection of lidocaine. To perform the procedure safely and successfully, you must have a clear understanding of pelvic anatomy. The bladder lies posterior to the pubic symphysis and anterior to the uterus in girls and anterior to the rectum in boys. We will demonstrate the procedure without and then with the use of ultrasound guidance. Place the child on his or her back in the frog leg position. You will need one assistant positioned at the child's head to maintain control of the arms and a second assistant to restrain the legs. Wash your hands with soap and water and don sterile gloves. Cleanse the skin from the umbilicus to the pubic symphysis using an antiseptic solution. You may choose to leave the diaper on during the procedure to reduce spontaneous urination. Drape the area to avoid contamination. Next, infiltrate the subcutaneous tissues approximately 1 to 2 centimeters above the pubic symphysis with 1 milliliter of lidocaine. Use the 1.5-inch needle to perform bladder aspiration. The needle should be placed at an angle that is perpendicular to the abdominal wall, which means the needle will be approximately 10 to 20 degrees from true vertical. Penetrate the skin and immediately apply negative pressure to the syringe as you advance the needle through the skin until the urine is visible. You may feel a change in resistance as the needle penetrates the bladder wall. If no urine is obtained after the initial attempt, withdraw the needle to the edge of the needle tip, but do not remove the needle from the skin. Then change the angle of needle entry so that the needle tip is more caught at. The needle should be oriented along the true vertical. Once you have collected sufficient urine in the syringe, immediately transfer the urine to a sterile container. The use of bedside ultrasonography to assess the bladder volume before you start the procedure and to guide aspiration can increase the likelihood that the procedure will be successful. The most common reason for not obtaining urine with suprapubic bladder aspiration is a lack of urine in the bladder. Ultrasonography can be used to assess bladder volume before beginning the procedure. Position the patient as shown earlier. Note the location of the indicator on the ultrasound probe and position it pointing towards the patient's right side. Apply ultrasound gel to the abdomen approximately 1 to 2 centimeters superior to the pubic symphysis and locate the bladder. Apply minimal pressure with the probe in order to avoid triggering urination. A full bladder in transverse view will appear as a well-defined triangular or rhomboid structure in the pelvis, containing black or anechoic fluid. In this orientation, the patient's right side will appear on the left side of the screen and the patient's left side on the right side of the screen. If you obtain measurements of more than 2 centimeters in all dimensions, you should be able to aspirate at least 2 milliliters of urine, an amount that is generally sufficient for analysis. If there is very little urine in the bladder, you may find it difficult to locate the bladder with ultrasonography. If this is the case, provide the patient with oral or intravenous hydration as appropriate to the clinical state of the patient, and try using ultrasound guidance to locate the bladder 30 minutes later. The amount of fluid you administer will depend on the size of the patient, the level of dehydration if present, and whether there is any known cardiac or renal disease. Once there is sufficient urine in the bladder, you may begin the procedure. Prepare a small amount of sterile gel and put on sterile gloves. Cleanse the skin with the antiseptic solution and place a sterile cover on the ultrasound probe. Locate the bladder again. If you are not using ultrasonography for real-time guidance of bladder aspiration, mark the skin site where the bladder is best visualized with a sterile pen and proceed with bladder aspiration as demonstrated earlier. For real-time ultrasound guidance, leave the probe on the abdomen and insert the needle midline and just inferior to the edge of the probe at an angle that is perpendicular to the abdominal wall. You should see the needle tip clearly on the ultrasound screen as it advances through the skin and into the anterior wall of the bladder. Once you see the needle in the bladder, aspirate the urine. Complications of suprapubic bladder aspiration are rare. They include gross hematuria, cellulitis of the abdominal wall, and perforation of the bowel, which may occur when a loop of bowel overlies the bladder. The use of ultrasound guidance decreases the likelihood of bowel perforation. If you suspect bowel perforation, withdraw the needle and reattempt the procedure with a fresh needle and syringe. Intestinal penetration is usually not clinically significant and generally requires no follow-up. Knowing how to perform suprapubic bladder aspiration is important for clinicians who care for children who are not toilet trained or who are unable to provide a clean catch urine specimen. When a sterile urine specimen from a patient is required and the performance of urethral catheterization is difficult or unfeasible, suprapubic bladder aspiration is the next preferred method.